one right.
There is no return of spontaneous circulation.
Oh, I think that's 2 sets. Right, superficial layers.
CPR.
He won't need it after this.
Okay, stop CPR.
Back side is close.
This video eloquently explains the importance of monitoring and treatment of intra-abdominal pressure. Good evening, colleagues. I, Dr. Astha Guliani, welcome you to the first online meet of Abdominal Compartment Society India chapter. The topic of today's panel discussion is intra-abdominal hypertension in critically ill patient. To discuss about the topic and answer our queries, we have Professor Manu Malbrain, internist, intensivist at Löwenjoel, Belgium. He is the Professor Critical Care Research at Lublin, Poland. He is also the President of International Fluid Academy and Treasurer at World Society Abdominal Compartment Syndrome. We also have with us Dr. Pardip Rangappa. He is Consultant Intensive Care Physician at Manipal Hospital, Bengaluru in Karnataka. He is the editor of Journal of Acute Care. We also have Dr. Supradip Ghosh. He is the head of Department of Critical Care at Fortis Hospital, Faridabad. He is the author of Handbook of Intravenous Fluid and Rational Use of Intravenous Fluids in Critically Ill Patients. We also have Dr. Parveen Kaur. She is head of Department of Critical Care at Rajiv Gandhi Cancer Institute and Research Center at New Delhi. She is also president of Onco Critical Care Society. We also have Dr. Saurabh Kumar Das, intensivist at Max Hospital, Shalimar Bagh, New Delhi. Effect increased abdominal pressure was studied by different researchers in different times, namely Ettony, Jules Mary, Braun, etc. In 1911, it was published by Emerson that elevated intra-abdominal pressure decreases blood pressure because of diminished venous return to the heart. R. Fietzam in 1989 coined the term abdominal compartment syndrome. J. M. Birch, M. Skeen published 2 important papers related to intra-abdominal pressure. In the year 2004, World Society of Abdominal Compartment Syndrome was started in Noosa, Australia by Professor Manu Malbrain and his 6 other colleagues. Later on, society has changed its name to Abdominal Compartment Society. May I know from Professor Malbrain, what was the intent behind starting the society and how is the journey so far?
Hi, Astha. Thank you. Thanks, everyone, for this excellent initiative. And I need to thank Saurabh, who is Chinese volunteer to become a kind of ambassador of WSACS in India. So it's a great pleasure and privilege to be here with you tonight. And let me tell you a little bit about the background of the society, which we had a first meeting in 2001, which was done by Michael Sugru from Sydney. And then in 2004, we had a follow-up meeting in Noosa. So when we were sitting there with colleagues from all over the world, we were having this idea to create this World Society. And you correctly mentioned we were only 4 to 6 colleagues to start a World Society, because we felt that there was an unmet need and knowledge gaps to better understand intra-abdominal hypertension and how it affects end organ function, as you nicely showed in the video of the series ER. So there was the idea behind some like-minded colleagues from all over the world. And the interesting thing is that we had internal medicine physicians, anesthetists, surgeons, burn care physicians. So abdominal compartment syndrome is not confined to one specialty. So it easily transgresses the usual borders between the disciplines, as we know. So while we were in Noosa, we sat down and started writing the consensus definitions. And when the first edition came out in 2006, I think still today it's one of the most cited papers in intensive care medicine, with almost 2,000 citations. So that confirmed that all over the world there is still a need to better understand this syndrome. So there's a long answer to your question why we started it in 2004. At some point, and I think COVID was not very helpful, we felt that we had done our job, and every colleague knows about abdominal hypertension and compartment syndrome, what it is and how to treat. So we thought of retiring the society. But after COVID was over, we discussed and we understood that still around the world, especially in low middle income countries, there is a need for ongoing education, training, surveys, research. And that's why we decided to move on. So we built the new members portal, and as we speak, I think we have almost 1,500 members from all over the world who joined the platform. And the idea now is to identify in each country an ambassador, an enthusiast, a couple of enthusiast people who would like to spread the knowledge within their own country. And that's, I think, how Saurabh and we got in contact, and he volunteered to do so. And next to that, I think there are many other colleagues from India who would also like to help. So the first step would be to perform the survey on the knowledge, so the basic knowledge. Where do we stand right now in India? Are we measuring abdominal pressure? Are we thinking about it? And then the next step would be to perform some observational studies just to look what is the incidence as of we speak today in India. Do we recognize it? Do we treat it properly? What about the fluid management? Are we over-resuscitating the patients, which may create abdominal distension and so forth? So I'm very excited. I'm very happy. And I think the first steps have been made with organizing this webinar, with launching the survey. And I think that Saurabh will tell us more about that, how many respondents and how we can promote this initiative.
Thank you, Manu, and the other panelists for joining us in today's webinar. We have a bucket of queries for our panelists, and we'll ask one question to one panelist, and another panelist also can interrupt, and if they have some other point of view or they want to add something. I'd like to start with some basic questions. We all know that intestinal function is a major determinant of outcomes in patient with critically ill patient. Working group of abdominal problem by ES, ICM, they have defined some definition. One of those is acute gastrointestinal injury. I'd like to know from Dr. Pardip, what is acute gastrointestinal injury?
Yeah, thank you, Saurabh, for the question, and nice to have a esteemed panelist here. So I think in critical care, we often see a lot of patients with multi-organ dysfunction. So when we say there is a multi-organ dysfunction situation where there is a GI dysfunction that has set in, not necessarily the GI dysfunction may be secondary to primary abdominal injury. It can be due to any other reason where the GI dysfunction sets in. So we call it as acute GI dysfunction or acute gastrointestinal injury. So based on this, I think they have correlated this GI dysfunction with the outcomes, and many studies are there to show that GI dysfunction has a direct bearing on the worst outcome or mortality. And based on this, I think they have done the grading of GI dysfunction. So they have graded about 4 grades of GI dysfunction. In fact, Saurabh, we have published a paper on constipation in ICU and its correlation with outcome. So if you look at the grading, So grade 1 is where it is self-limiting and it portends that there may be future GI dysfunction that may be setting in or GI injury that may be setting in. So the secondary dysfunction is where it is a reversible, and constipation is one of them, where you, without intervention, there is restoration of. So a simple thing as constipation, which I'm sure very often we tend to overlook, because many a times you would see, if you have made observation where we presented this, we did a study, one of a trainee, it was shown many of the ICU patients do get constipated and seldom it is addressed. And the longer the duration of constipation had a direct bearing on their outcome. So, and then the grade 3 is where there is a GI failure, where some sort of an intervention would be needed to fix the GI dysfunction, like it could be stress ulcer or it can be progression of intra-abdominal hypertension, so on and so forth. And grade 4 is life-threatening, where there is a GI failure and where it portends that there is an imminent sort of a risk to the life. And there are multiple studies to determine that when there is a GI dysfunction associated with increasing age, the mortality is much higher. Or if it is associated with the duration of mechanical ventilation, the mortality goes up to even up to 63-fold higher. And with every additional days with GI dysfunction, it has a direct correlation with mortality. So that is what we have understood until now, that GI dysfunction is one of the major organ dysfunction. When we are categorizing different organ dysfunction in ICU, seldom do we say there is a GI dysfunction associated. We'll call it as lung dysfunction, cardiovascular dysfunction, hepatic dysfunction, renal dysfunction, but GI dysfunction is seldom spoken about. So we need increased awareness on this. Over to you, sir.
Thank you very much for your answer. Yes, Dr.
Yeah,
Saurabh, please.
No, please go ahead.
Thank you for your answer. Now, we know that acute gastrointestinal injury type 2 includes intra-abdominal hypertension, grade 1, whereas acute GI injury, grade 4, denotes abdominal compartment syndrome. Now, I would like Dr. Parveen to shed some light on intra-abdominal hypertension and abdominal compartment syndrome and the risk factors for the two.
Good evening, everyone. So when we are talking about any topic, it is very, very important to know the definitions. As we all know, normally intra-abdominal pressure, it is 5 to 7 millimeters of mercury in critically ill adult patients. So when we talk about, by definition, IAH is sustained. These words are very, very important. Sustained or repeated pathological elevation of intra-abdominal pressure more than or equal to 12 millimeters of mercury is classified as, or is defined as, intra-abdominal hypertension. So there are 4 grades for this. Grade 1 is, everyone is aware of these grades, but just for the sake of completing it, grade 1 is when IAP is 12 to 15 millimeters of mercury. Grade 2 is 16 to 20 millimeters of mercury. Grade 3 is 21 to 25 millimeters of mercury. And grade 4 is when IAP is more than 25 millimeters of mercury. So when we talk about abdominal compartment syndrome, any compartment syndrome is whenever the pressure increases in any compartment, which leads to organ dysfunction. That is, by definition, becomes the compartment syndrome. And abdominal compartment syndrome, when we are talking, so sustained IAP of more than 20 with or without an abdominal perfusion pressure of less than 60, which is associated with new organ dysfunction, as I have already mentioned. So that becomes abdominal compartment syndrome. So, so there are 2 types of abdominal compartment syndrome, primary and secondary. Primary is when the primary pathology is in the abdomen, and secondary when it is associated with other risk factors or other conditions. And there is another terminology which is recurrent ACS. So the condition in which the ACS, I'll be using abdominal compartments, ACS for abdominal compartment syndrome. So the condition in which ACS redevelops following previous surgical or medical treatment of the primary or secondary ACS. So these are the definitions which we when we are talking about intra-abdominal hypertension. So coming on to the risk factors for ACS. So first is abdominal wall compliance issues, then intraluminal contents. Third is abdominal content, and fourth is related to capillary leak and fluid resuscitation. So when we are talking about just for the completing the list, when we are talking about abdominal wall compliance, prone positioning that very much predisposes to abdominal compartment syndrome. If the head of the bed is more than 30 degree, that is another risk factor. Any surgery, primary abdominal surgery, abdominal trauma, burns, tight dressings, tight fascia closures, these all conditions, they predispose to ACS. And then when we talk about intraluminal contents, as Dr. Pradeep has already mentioned, that gastroparesis, ileus, colonic pseudo-obstruction, these are all risk factors for development of ACS. Then abdominal contents, as we know, pneumoperitoneum, hemoperitoneum, ascites. I work in a onco center, so we see lot of omental deposits. Many malignancies, they have omental deposits. They exactly lead to intra-abdominal hypertension. I think this is one thing which is less studied, less explored. But omental deposit, it is a serious problem. And fourth, which is associated with capillary leak and fluid resuscitation, which is one of the most commonly seen conditions. Any sepsis after initial resuscitation, it leads to capillary leak and its sequelae, which can predispose to abdominal compartment syndrome. So the deadly combination of acidosis, hypothermia, hypotension, polytransfusion, which is very common in an onco setup. In hematological patients, we see a lot of transfusions in a patient. Then initial fluid resuscitation. So these are all the risk factors for development of ACS. Over to you, Astha.
Thank you, Parveen, for explaining nicely about the risk factor and the definition of this. Manu, would you like to add anything? Professor Manu? Your audio is
Yeah.
down.
I think it was quite complete. The only thing I would like to add is that over the years, we see less and less secondary abdominal hypertension because we are more and more aware of the iatrogenicity of overzealous fluid resuscitation. And I guess 10, 15 years ago in my ICU, which was about 1,000 admissions a year, we saw 20 cases of open abdomen, decompressive laparotomy. Whereas more recently, let's say it's about 1 to 5 cases a year because you do the preventive measurement, like looking at fluid balance, sedation, curarization, paracentesis, and these kind of things. With regard to the AGI, I think that the idea behind is that we wanted a SOFA score for the intestinal tract. We know how to quantify AKI. We have urine output, we have creatinine. For the lungs, we have PF ratio, but for the gut, it's very difficult. And abdominal pressure may be helpful, but it's not ideal. So we're still looking for a good biomarker for gastrointestinal function. Thank you.
Thank you. Thank you, Manu. Now I would like to go to Dr. Supradip. We want to understand from you what is the effect of IAP on the other organ function? Like what is the pathophysiology of organ dysfunction due to the IAP?
So first of all, Saurabh, I would like to congratulate you for organizing such event. And I'm thankful to you for giving me the opportunity to be here. Now, coming to the question, I think there are two aspects to it. One aspect is the impact of the common pathophysiology, which can involve both abdominal compartment and other organs of the body. So one pathology, like mostly they are the secondary causes of ACS. So a pathology which is causing abdominal compartment syndrome also and other organ systems also. As other issue is the intra-abdominal hypertension as such, how it impacts the other organs. So if we see, let's start from the abdomen itself. If the pressure is elevated, obviously the perfusion of all the organs inside the abdominal cavity, be it the liver, be it the gastrointestinal tract, or be it the kidney, their perfusion gets impaired. So you will have the impact on it, be it in the hepatic function, be it in the gastrointestinal function. including edema and translocation of the bacteria, or be it in the formation of the AKI, because of the perfusion is defective. But it also have an impact outside the abdomen, because the abdominal pressure is elevated, the diaphragm will be pushed up. The diaphragm being pushed up, there will be an increase in the intrathoracic pressure. Raise in the intrathoracic pressure will have impact both on the heart and on the lungs. Let's look into the lungs. What will happen? If there is a push of the diaphragm, there will be atelectasis. And this atelectasis will cause hypoxia. Both because of the atelectasis and hypoxia, we can have an impact on the pulmonary pressure, pulmonary arterial pressure. So we'll have a pulmonary arterial increase in the pulmonary arterial pressure. Intrathoracic pressure increase, and because of the rise in the pulmonary arterial pressure, we can have a cardiac effect. The preload to the heart will be decreased because the intrathoracic pressure is increased. I mean, the right-sided heart, intrathoracic pressure is increased. At the same time, the right side will have an increase in the afterload because of the pulmonary arterial hypertension. Similarly, we can have a afterload of the left side also increase because of the, again, raise in the intrathoracic pressure. So it's a complex effect. Each organ like lungs or heart in the thoracic cavity will be impacted directly by the intra-abdominal pressure elevation. Finally, we can have because the intrathoracic pressure is elevated because of the secondary effect of the intra-abdominal hypertension, there will be an impairment of the delivery of the venous drainage of the brain. So you can have some elevation of the cerebral pressure. The perfusion pressure will be impaired of the brain. So each and every organ system, indirectly or directly, is involved by intra-abdominal hypertension itself. Apart from the effect or impact of the etiology of secondary abdominal hypertension, which is causing effect in every part of the body. So I think briefly, this much I can think of.
Thank you very much, sir, for telling us how every organ system is affected by intra-abdominal hypertension and how it can lead to multi-organ dysfunction. Now, I would like to ask Dr. Pardip to tell us about adaptations and ventilator strategies that may be required in a patient with intra-abdominal hypertension.
Yeah, thank you, Astha. I think Supradip has answered first of it as to what happens with intra-abdominal hypertension and compartment. See, I think when we say compartment syndrome, obviously, as Supradip has mentioned, it has affected other organs, and lung is possibly the second most important organ that tends to get affected maybe early on after acute kidney injury. So the ventilations, they do get hypoxemic because of diffusion impairment, and there can be ventilation perfusion mismatch, and there is increase in the dead space and reduction in the functional residual capacity. As already alluded to, because the diaphragm is pushed upward, so there will be basal atelectasis, and there would be ventilation perfusion mismatch. There is increase in the shunt fraction, and this increase in the dead space also can happen, which can be compounded even by ongoing serositis or pleural effusions, which is very often the case in common situations we see more so with pancreatitis. So the strategies of ventilation, if a patient is mechanically ventilated, would be to address all these. And lung protective strategy seems to be appropriate with the protective ventilation with a low tidal volume and PEEP optimization. So the whole and dead space, we have to minimize the dead space. So obviously, if you have abdominal compartment with a pleural effusion sitting in there, and you are having difficulty with airway pressure, so obviously you have to reduce the dead space. And if there is any collections has to be drained, and there has to be decompression of some sort with a nasogastric tube, with a Platus tube in the abdomen, and maybe decompression of the abdomen if it is not settling with all this. So lung protective ventilation and neuromuscular, if things are not settling with all the standard measures that you would put in place, like reducing dead space, optimizing PEEP, low tidal volume, and addressing the sort of pleural effusions that may be there, or bronchospasm, so on and so forth. If things are not settling in, then obviously we have to use muscle relaxants, neuromuscular blockers to relax and reduce the peak airway pressures that may be happening. So the one contentious issue in ventilation, in ARDS, it is very easy. We adopt protective lung ventilation, we give neuromuscular blockers, we sedate the patient, we maybe give steroids in the early ARDS, so on. But we have an option of doing proning in ARDS. But in abdominal compartment, if all these strategies are not successful in achieving good normoxia and hypoxemia is still persistent. So there have been few interesting sort of observational studies on proning in intra-abdominal hypertension abdominal compartment. Just to draw in maybe comments from Professor Malbrain as to if any proning has been done, because proning is contemplated to increase the intra-abdominal pressure. So because it does, but it's shown to reduce the chest compliance and increase the abdominal compliance, and that is shown to be helpful in improving oxygenation. And it is shown that abdominal compliance also can be improved. So as a alternative to this, considering proning may be difficult with all the abdominal pathology. If it's a pancreatitis who's undergone some procedure or abdominal surgery, proning may not be very easy. So there is a hypothetical observation, or rather there has been observation by keeping the weight on the chest and putting suction on the abdomen to improve the abdominal compliance. So this is more like experimental setting. They have done it, and it has a similar effect of advantages of proning. So that is something that possibly more observations have to be made with such strategies, putting the weight on the chest and putting a suction over the abdomen. So this is in the extreme situations where all the protective ventilatory strategies have failed. Would something of this nature should be adopted? Maybe more studies, more observations need to be made whether this is feasible. So there's a nice diagram on the manuscript that has come out on this. So would like to hear comments on this from Professor Malbrain, whether any such attempts have been made in his setting. Over to you, Dr.
Thank you, Pradip. I would like to know, like, as per the AIDS protocol, we limit our P plate around 30. But when the patient is having high intra-abdominal pressure, should we keep below 30 or we can go beyond that? Or like, can we adjust our PEEP as per the intra-abdominal pressure?
I think from whatever reference I could find, we can tolerate a little higher. There is no sort of indication as to the driving pressure. Obviously, in ARDS, we need driving pressure less than 15 and P-plat to be less than 30. So I think in abdominal hypertension, considering that you have a, the abdominal hypertension which is contributing, so higher 35 is what is seen to be acceptable, but we need more observations. So this is all more on a hypothetical modeling that suggestion is made that we could accept a higher P-plat in these patients, Saurabh.
Thank you. Manu, do you want to add anything?
Can I ask, Saurabh, can I ask a simple
Yeah.
question to my friend Manu?
Sure.
Yeah. Manu, there is an old concept of physiological PEEP. One reason could it be that since and we give around 5 centimeter water of PEEP to most of our patients, whether they have ARDS or they do not have ARDS. Could it be because the abdominal pressure is something around 5 to 7 millimeter of mercury normally? It is just to counter that we give some physiological PEEP, and because of that, in your PAL thing, you have used same whatever may be the abdominal pressure, apply the same positive and expectation, just to make it very simple, that whatever may be the pressure of the abdominal pressure, intra-abdominal hypertension, keep the PEEP the same in centimeter of water. And this is what you have used in your PAL strategy. I'm just curious whether our concept of physiological PEEP is just to counteract the balance, the abdominal pressure we have inside our normal abdomen, and your PAL strategy is just to counter the same pressure when the patient has got intra-abdominal hypertension.
Yeah, it's a very good point raised, Supradip, and I like it. Of course, the recruitment and de-recruitment of alveoli and the opening and closing and the shear stress will be dependent on many factors like the time constants and the resistance and the compliance of each individual alveolus. But it makes sense because the thing that you want to prevent is collapse of the alveolus at the end of expiration. That's why we think setting a little PEEP will prevent that. So you won't have the opening and closing of certain amounts of alveoli. So probably, yes, I can't give you a definite answer, but it makes sense why we put this kind of physiologic PEEP of 5. But putting the PEEP in centimeters of water equal to the intra-abdominal pressure in millimeters of mercury, when you have the conversion factor of 1.36, takes a little bit into account the average transmission from the abdomen to the thorax, which could be, depending on studies, something between 30–50%. So the fact of setting the PEEP equal to intra-abdominal pressure makes sense, because at the level of the diaphragm, the pressure difference will be 0. So you will just avoid the control of your basal lung regions. But adding to what Pardip said, I think first is important to open the lung, to recruit the lung. And I think for the delegates here, they must be aware that opening pressure, peak pressure, is the pressure that recruits on a continuous basis in the PV inflation loop. So you need to have much higher opening pressures. So if you would have a 40/40 recruitment maneuver, 40 centimeters of water for 40 seconds, in abdominal hypertension, let's say with IP of 20, you probably need a 50 or maybe even a higher opening pressure. That's one. And then for lung protective ventilation, to keep the lungs open, I would say, as a rule of thumb, PEEP equals E up. PEEP in centimeters and IP in millimeters of mercury. So you have the conversion factor. And then you mentioned prone positioning. There is some data showing indeed that when proning the patient, abdominal pressure increases on average with 3 to 4 millimeters of mercury. So by putting suspensions, so to put on the pubic bone and on the sternal bone, and you let the abdomen hang freely, which creates a kind of a gravity force, and this will help in recruitment of dorsobasal regions. And that's why when you prone, because you rest on the sternum, you will decrease thoracic compliance. And by putting a weight when the patient is supine on the chest, it's kind of the same. You decrease compliance in the ventral region, so you will force the tidal volume to recruit dorsobasal atelectic zones. But I only found one abstract in 7 patients or something that has been published so far, but it makes sense from a physiologic point of view.
Thank you, Manu. Now,
just to add, Saurabh, for the question you asked on the plateau pressure, I think they have put in one formula that you can accept higher. That is mean P plat minus 7 plus 0.7 into IAP. So that is the sort of acceptable P plat for patients with intra-abdominal hypertension. But basically, it's negating your intra-abdominal pressure. So that formula is something that you could refer to determine what is the P plat that can be acceptable. So that's why I think we kept a little above 30–35 is acceptable, but that formula can be used if you are dealing with very dynamic changes in the pressure.
Absolutely. And we wrote a formula with Paolo Pelosi, who unfortunately passed away last year. And the reason of having the 7 is because normal abdominal pressure in critically ill is 10 millimeters of mercury. So conversing 10 millimeters of mercury to centimeters of water gives you the 7 when you're talking about alveolar pressures or plateau pressures.
Thank you. Next, I'll go to
Saurabh, can I just
please.
comment that, see, we know that with the discussion from Manu, we know that, okay, we can set the PEEP in whatever may be the intra-abdominal pressure, set the PEEP in the same. We know from our data that driving pressure should not exceed 15 or 18 centimeter of water. So if you have the PEEP, say 5 or 8 or 10 or whatever, you add 15 or 18 to that, and that can be our initial target plateau pressure for the sake of simplicity. Can we do that? I'm just curious. So say
Yes.
our abdominal pressure is 15, say. So I set a PEEP of 15 millimeter mercury. I set a PEEP of 15 centimeter of water. I know that my patient's plateau pressure should, driving pressure should not exceed 15 from the study of Marcelo Amato and all. So 15 plus 15, 30. But if the abdominal pressure goes up, our plateau pressure will go up. I'm just curious, can it be possible?
Yes, no, exactly. But I would look at plateau pressure after recruitment. Because
Yes,
if you
of course,
start
after
from the peak
recruitment, yes.
and add, so do it inverse, you recruit and then you come down to the plateau pressure that you can calculate and check the tidal volume. If it's around 6 ml, you're fine. But sometimes there may be other issues, or if you really have a very poor chest wall compliance, like an obese patient or a patient after cabbage surgery, then you may end up with tidal volumes that are very, very small, and you will just have dead space ventilation. And if you would take into account the driving pressure limitation on an individual patient.
If my PEEP is causing recruitment, then driving pressure should not go high. If my PEEP is not causing recruitment, it's causing distension, then driving pressure will go high. I think in that way.
Yes, if the PEEP is improving, yes, recruiting, the compliance will improve, the automatically driving pressure
Driving should not increase.
But our limit should be this, that we should not exceed this. Say, for example, if I set a PEEP of 15 and the driving pressure, suppose I make a maximum plateau pressure of 30, but in that, if my tidal volume exceeds 8 ml per kg body weight, I can reduce to 6 ml per kg body weight. In that case, automatically my driving pressure will go down. This is one way we can do the things till the time we get more data.
Thank you. Next question again to Dr. Supradip. You already discussed about its effect on hemodynamics. I want to know, like, whether the parameters we use, like stroke volume variation, dynamic and aesthetic parameters like like PLR, like SGB, can we use also in this patient with same accuracy? And like some also days we usually target MAP while doing hemodynamic resuscitation. And some people, they also recommend that we can also target abdominal perfusion pressure when IAP is high. What is your take on this?
Okay. So as we have seen in the pathophysiology that there is a huge impact of abdominal hypertension or increased raised abdominal pressure on the preload and the afterload. Obviously, there will be impact of these on heart-lung interaction-based dynamic parameters, as well as the static parameters. If you see the static parameters, that will be like CVP and PAOP, they will be elevated. So this will be not a good parameter for doing the thing. Anyway, we have reduced our use of static parameters for the sake of fluid responsiveness. But if you go for the more commonly used parameters like PPV, SPV, they will have an impact, because there will be a false if we use a cutoff of 11% or 12% as suggested by the majority of the studies, then there will be a very high false positive result because of this. But if we can use, we need to have more data. I mean, perhaps in future, if this society grows, we'll be able to do more studies on such subjects. What should be the cutoff for? It has to be a higher cutoff. What should be the cutoff for such level of abdominal hypertension? What should be the cutoff for this level of abdominal? Maybe in future we can think about that and go this thing, or whether we can at all use it. If we go for I think end expiratory occlusion pressure is something which can be useful irrespective of the abdominal pressure. That 5% elevation of cardiac output after 15 seconds of abdomen end expiratory occlusion, that if you press the button for it, can still be useful even irrespective of our abdominal pressure, whatever may be the abdominal pressure. What about the IVC? IVC distensibility probably will be impacted strongly by the presence of abdominal pressure, because inferior vena cava itself is inside the abdomen. and the results will not be reliable as in a patient with a normal abdominal pressure. What about PLR? Yes, there are controversial data. Some people believe that PLR can still be used, but many others believe that PLR, because again, when we do the PLR, out of the 300 ml of blood, a large amount comes actually from the abdominal compartment. So they will have an impact in the things. Again, PLR will be falsely positive, negative, whatever. PLR will not be a very reliable in things. But I think superior vena cava collapsibility, which is superior vena cava being completely in the intrathoracic compartment, and expiratory occlusion test, these are the two tests which may still be useful in abdominal when the abdominal pressure is high. But definitely no PPV, SBV, SPV, and all these things, they require more validation in different types of abdominal pressure. And Manu can help us.
And some author they suggest like the pressures are not reliable, but the volume are still reliable. You can still rely on the volume. And like, what about like using abdominal perfusion pressure instead of MAP? Because MAP may not be a appropriate target in case of fluid resuscitation in this patient.
Shall we target MAP at all for fluid resuscitation? It's coming to the fluid resuscitation. Our target of fluid resuscitation is to achieve perfusion of the tissues, tissue perfusion. And to do that, we need to see whether the patient is hypoperfused or not. We need to see whether the patient is fluid responsive or not. Fluid responsive, whether there is a good possibility of improvement in cardiac output following a fluid bolus. And thirdly, that we should be quite confident that the patient is not fluid intolerant.